Okay, today we are going to talk about the business of healthcare, and it's kind of it's a very interesting interview because this person has worked in pharma, in healthcare systems, in education, and it was great to actually and very positive. So I would encourage you to listen to that
Yeah, I'm gonna read his bio for everybody and
and
give
and
them some
and blow
background.
everyone's minds and make you feel like you've wasted your life when you listen to his bio.
But not only that, we are talking about in our thoughts on what's partially not wrong with healthcare, how you, the listeners, if you're not actually in the healthcare system, can do your part maybe to make things better, what's kind of down the pike in some technology, and looking forward to where we might be in 10 or 20 years, what to expect. And we just brainstormed on some thoughts, but it was great to get his opinion from a non clinical person instead of us always beating the drum with our ideas as doctors. Um, and our guest, James F. Jordan, is a healthcare and life science expert. He's a distinguished service professor of healthcare and biotechnology at Carnegie Mellon University's Heinz College, the president of Stratactic, the national co-chairman of the Bio Bootcamp, and the founder of the Healthcare Data Center. He has published numerous articles and books on innovation, startups, intellectual property, and health systems. He's been a senior executive for Fortune 100 companies and has participated in and led angel and venture capital investments. And as the CEO of the Pittsburgh Life Science Greenhouse, where he worked with 493 companies and invested in 93 of them, Jim has held high-ranking positions in Fortune 100 companies such as McKesson Corporation, and he served as senior vice president, Johnson and Johnson, where he was the vice president for marketing and many other noteworthy adventures. He's an amazing speaker. He's, like I said, an author, consultant, works with hospitals, health systems, medical devices, pharma, diagnostics, biotech, and health IT. And basically is an active industry expert looking for ways to improve the business of healthcare. Amazing bio, amazing involvement across the board. And we had an amazing talk with him. So hop on and take a listen. All right. Welcome to the show, Jim. I guess I can call you Jim since you've got Jim there in bracket instead of James. It's more official. We're super excited to have you on BS Free MD today.
Thank you. It's a pleasure to be here.
So, I why don't you just tell our listeners a little bit of your sort of summary of your venture into the healthcare industry? You're not a physician, but um, how what your background is exactly, your training, and kind of where you bring us up to speed really fast in
Yes.
5 minutes of how you got into this industry and where you're at now.
So I got into this industry. I started in cooperative education and I did Patriot missiles, and I thought technology was really cool. And as I was graduating, I recognized that we were potentially killing people as opposed to helping people. And so I found my way into healthcare. And I started in finance. I've worked in operations, engineering, quality, plant management, sales. I've done all aspects of medical devices and specialties: vascular surgery, cardiology, radiology, general surgery, robotics. And then I found my way to McKesson, and I got into pharmaceutical and distribution. And it was there where I really started understanding the business of healthcare. And in 2007, I went up to Carnegie Mellon University, and I knew that the dynamics of the population were going to require some change in healthcare. And I started talking to the dean about their participation in healthcare, and I amused him, and he hired me. And so that started my journey into healthcare. And at the same time, I was a CEO of a nonprofit at the same time, focused on taking technologies out of universities, drugs, devices, medical devices, healthcare IT, and putting them through the venture capital system. And so at the same time, I had sort of this theoretical education going on and seeing the venture side. So I've seen the manufacturing, the distribution, the retail side. And I started teaching this course at Carnegie Mellon University called Health Systems. And it was really to take our master students in healthcare and biotechnology and digital health, was to give them a sense of all the business models. And so I started doing that, and I had a faculty that was the most talented people in the world. And so I started building a website so we could sort of coalesce around our vision. And that website can be seen today, 20 years later, at healthcaredata.center instead of .com. And that's really how I got here.
So I want to jump in and, as we were, pre-briefing before the show, how important healthcare business is. And again, there's a little bit of a kind of, you feel a little bad saying business and healthcare together. It's
Yeah,
like,
we were talking about that.
and
The
it's like,
business of healthcare.
but it's so critically important. I mean, it's just like personal finance. Like, you have to take care of yourself financially, or your house is not in order and you can't take care of the other things. So the business of healthcare is what everyone kind of complains about. If you have an access problem and can't get doctors, it's because there's a market issue that needs to be solved. That's a business problem. If your health insurance is too expensive and it doesn't have the coverage you want, that's a business problem. So these are really central issues to everyone's concern in healthcare. And I bristle a little bit when you get into these political debates and they make it sound like it's so simple. Like, we'll just give Medicare to everybody and it'll all just be fine. Well, it's a little more complicated than that. It's way more complicated than just insurance. I've always said giving everyone health insurance is kind of like treating world hunger by giving everyone a fork. It doesn't, it might be part of the problem, but it's not the solution to the entire problem. This is a massive industry with lots of complexity and lots of issues. And you've obviously worked through tons of those.
And we were talking about the business of healthcare, and there's no business that's not successful by not having a delighted customer, right? And so
Exactly.
that's why we talk about the business of healthcare. But it's interesting, the debate that you talked about, because we were talking earlier. You're Canadian. You come from one system originally, and there is a moment when I teach at Carnegie Mellon University where I'll ask the question whether healthcare is a right or a privilege. And of course, I'm trying to stoke up the right and the left and get some things going. And so you get pretty going, and you get them trying to convince each other. And I said, at the end of the day, isn't the point that if I take the people that think it's a privilege, and I said, if I could shave off 10 percentage points of our gross domestic product spend on healthcare by including everybody, reduce your tax rate, and invest in innovation to grow the economy, would that be something that would interest you? And they say yes. And so I think it's really about trying to, as we have this debate of right or privilege and did someone earn it or not earn it, as an economy, gross domestic product is how we get successful, and that everyone being productive, right? And so the question is, what's the best way to get there? And unfortunately, we have a system that, started, I remember when I was a kid, my doctor came to my house to visit my grandmother. I mean, and the doctor was the person that provided patients to a hospital. You sent your relative to a hospital because you couldn't take care of them. And so doctors became really the sales rep for a hospital, if you think about it. And so the whole system started there. And today we're trying to get to the point where we're value based, right? Where we're paying for total care. And that's a great vision. But the problem is, along the way, the people that are getting punished a lot of times are the physicians in that process, and they're the ones that aren't having control over those business models that work on value. They're taking care of their piece of it. And so it's a very complex problem, and the question is, how can we deploy technology? We're talking about the whack-a-mole game at the carnival, right? And those moles are coming up, and we're whacking them away with the mallet. And the question is, can we use technology to get some predictability in that? And is it something that can be actionable? And then at the same time, the entire healthcare system by its very nature is acute driven, and it's the prevention that's going to really turn the dial for us. And that prevention is outside of the healthcare system itself. And the real question is, how do we incorporate that, right?
But
I love it.
Yeah, you nailed it.
So
the prevention part is outside of the system.
Right.
'Cause-
I want to just jump in and back up a little bit, sort of to put an umbrella over it. So thinking, going back to the business of healthcare, I was thinking, growing up in our Canadian roots, where socialized medicine was how we grew up, and still it's socialized medicine. People pay their taxes. That covers their health care for the most part, other than their
Just
drugs or their dentist or their all these things I'm going to start naming. Right? People in the U.S. think it's all free, and it's not. There's a lot of things you pay for, and but do we have to look at it first? Is there a political divide in a way? Like you say, some people look at it as a business, some people look at it as a privilege or a right. Do we have to kind of, you're right, kind of meet in the middle with that first before we can solve this issue? Because I think that growing up in Canada, people looked at healthcare as a right because it was just you paid your taxes and then you needed to get that you paid into it, so it was your right to get it back. And it's a one payer system. The government is the payer. Whereas in other countries, I'm thinking like New Zealand or countries that do have a two-payer system, it's both. It's basic things are rights. They're not going to let you die from your ruptured aneurysm or your appendicitis or your infant that's demising. But other things, starting with the really egregious or the crazy, like plastic surgery, elective things, cosmetic procedures, to my LASIK eye surgery, or I want my knee replacement in 3 months instead of 6. Things
no,
that,
instead of 2.5 years.
or things that aren't critical. Those to me are more, I wouldn't say it shouldn't be, maybe you're right, but more of a business because I could afford to buy into that. So is there I'm starting kind of basic and saying, do we need to kind of come to like a middle ground in a way on agreeing that yes, healthcare is a business for sure in the US. It's big business.
But it's a business in Canada as well.
And people in Canada don't see it that way. And so maybe trying to find some
I think healthcare in general, and it's certainly true for public health, but it's a defense to protect your economy. I mean, really is, right? So the whole idea is how do we keep people healthy and contributing and having everyone, you know, give the best they can and
Right.
make the whole economy, which when you say economy, it's not just about money, it's quality of life, it's all these other things. And so in the debate that I have at Carnegie Mellon University, what I'm trying to do is change the discussion from right or privilege to what's a higher goal that we can all sort of debate and compromise on. And I think that's a challenge because I do think that I have friends in Canada. I have a friend who had to bring his dad to Boston and pay out of pocket to have a heart valve done because they were done for the year in Canada and he wasn't going to get one in time, meaning he'd expire. And I had a conversation with the gentleman in France a few weeks ago, and there's two-payer system there, but there's one administration system. And so I interviewed a doctor from my podcast the other day who's a solo practitioner, and he has no less than 15 different contracts, 15 different ways of getting paid. And so imagine not even knowing how to project your revenue. If I've got 40 Parkinson's disease patients, but I've got 15 different ways of making money on them. Well, someone has to keep track of that, right? And so I think our system's very complex, but it comes down to the goal. What's our goal? But breaking up those systems and getting down to, one insurance method, you can, we have a international classification of disease system that's been embraced by the world in terms of how we talk about things. Why can't that be the basis of a healthcare system? But these are very complex things, and there's lawyers, accountants, and all sorts of other people in the middle there. But going back to the point, the goal is, how do we improve everyone's health? And a very interesting story. So I was a CEO of a nonprofit a couple of years back, and a letter came to the wrong address, and we were in the south side of Pittsburgh, and this is still sort of a rural neighborhood, or the city neighborhood rather. And so I decided, it's a beautiful sunny day, I'm going to walk and deliver this mail myself. And there was a woman that came to the door with a walker. She had oxygen on, and she asked me in, and I went in. We started having a chat, and she was only about 65 years old. She looked a lot older, but she was a smoker and all these kinds of things. And she was saying how wonderful her son was, that he's come back from college and he's taking care of her, and now he's working at Burger King. Well, there's nothing wrong with working at Burger King, but this person was going to school for engineering at a pretty prestigious university, and he came home to take care of his mom. So the implications of poor health is multi-generational, it's complex, it causes housing issues. So it's a real challenge. And so going back to the point that we were talking about earlier, we had mentioned that the healthcare system, the way I look at it, is sort of like a donut. In the middle is the 18% of our gross domestic product committed to healthcare. Then you've got all these other consumer companies that are really great at delighting people and gathering personalized information that can be predictive, and they need to be part of this. And so I think they're going to be the ones that bring the cost down. The question is, how do we make a system that makes sense that they can participate? And I think we're just starting to see that. I mean, I think we've had two examples in the past 24 months of, Amazon's been trying this for 25 years, had a lot of failures early on, because early on they said, I'm going to Amazon the healthcare system, and it didn't work. But their past successes have been, I'm going to take my Amazon skill and I'm going to combine it with people that are skilled in healthcare, and we're going to deliver something special. And I think we've seen that. And then you see what Oracle did with the VA is they came in and they said, we're going to take our software and we're going to, not specialize it. And they had all sorts of issues. And fortunately, the VA is giving them time to recover. But I think that's a very hard learned lesson. So the question is, how can we do more of the Amazon stuff, and how quickly can we teach these other companies to be able to get in there? Now, the challenge is that with all this technology and all this excitement, we have policy conflicts, right? So we have, on one hand, digital health policies and opening up the electronic health record and all these other things that are good. And then on the other hand, we have cybersecurity issues and data breaches and other issues that are high penalties for the problem, right? And so that slows down some of these things, because our infrastructure for IT historically in hospitals is very legacy driven, and cloud computing and all these other things are very affordable ways to scale. And to show how that has changed, when healthcare reform happened, the consolidation of physicians going to work for someone in the United States went up dramatically. And part of that was the high cost of IT that they were going to have to absorb. I spoke to a gentleman in New Jersey last week who's left and created his own practice. And I started talking about that. And he said, I can get all that stuff in the cloud now on a seat basis. And so that's progress.
Yeah, and the telehealth part is fascinating. We did an episode on it almost 2.5 years ago. Was one of like our episode 3 or 4 or something like that. But it's interesting because I thought after COVID that telehealth was going to just be becoming much more sort of standard operating procedure, and it really hasn't. And a lot of it, some of it is regulator driven, which drives me crazy, because with our podcast audience, I could just have a family practice in the entire country if I had a license in the entire country, and people would consent to just see and it would be easy to do from my perspective. Impossibly hard to do from a regulatory part, to get all the pieces right. And the malpractice carriers don't want to insure you for telehealth unless the patient has seen X number of times, and that's different in every state. And it's just, so you just throw your hands up and say, I go, okay, I'll just go get a regular job. So there's a major hurdle. But at the same time, a lot of the telehealth stuff was really driven by the patient, and patients still want to be seen in person. And really the demand went down, not from these regulatory hurdles. It went down because there wasn't patient demand for it, which I found fascinating, because now I'm talking to patients in the small town I live in, and they've moved from bigger cities because all of their jobs stayed online. And so other industries, if you're a a customer service manager or whatever, you're never going back to the office. That's never going to happen. So they can live in a smaller town, save some money, go fishing at lunchtime, right?
Maybe that's the problem. The
And-
only person that get to see is you, the doctor. So that's how I'm getting get out of the house.
Yeah, right. I want to sit in a waiting room for 3 hours and read a book without my kids.
Hey,
I don't know. Maybe that's what it is.
So I think, so prior to COVID, I sat on a few board of directors with some insurance company people, and we talked about telehealth, and they clearly didn't want to support it. It's very clear. And so when COVID happened, it's plus where there were these codes forever that we've been trying to get approved that got unlocked. And the insurance company person that I was talking about here would say, after COVID, those codes are going to go away. I said, they're never going to go away. And so the good news is they haven't gone away. The question is balance and customer demand. So I'm in the city, and my experience is patients having a reluctance to go into the city when they can do a telehealth visit. I have seen people that, would show up at their appointment, 10 minutes before and get a text that says come in and go right in, that now are going in and having to wait. And I've heard stories of people walking out and saying unacceptable. So I think that there's probably as many stories on this topic as we could figure out. But I do think it, to your point about the consumer driving it, the patients driving it, is going to be important. Now, at the same time, I have a couple primary care friends that will say that, there's only certain things that they can pick up by physically seeing a patient. And so on certain topics. But I do think there's a wonderful story. UPMC Cancer Center is pretty predominant. And there was a paper in the article on what they did to help people, because they told a story of a couple in their 80s that he had cancer, and he'd have to come into the city for his checkups. And it was a 2.5 hour ride, and he'd wait here for a few hours, and then he'd have another ride back, or they'd stay overnight. And the article went on to talk how physically exhausted he was from this process. And so what UPMC did is they put these centers in the middle of the state. And I wouldn't say that, I don't know what you call the center, because it's not a telemedicine per se, because there's a nurse there that can do certain equipment and get certain things to the doctors. But it took down this gentleman's time. And so he has certain times he has to come into the city, but other times not. So I think it's going to be interesting, because we're going to have this huge shortage of physicians in rural medicine. And I think, telehealth has to be, and telemedicine has to be the answer to that. And so I think we're going to find these sort of hybrid centers. And then I also think that you're going to find that if the hospitals won't do it, you're going to find private practices that are going to do it, and maybe take some of that up.
Yeah, I agree. I think maybe it's just the bias of where we live in. The type of person that's attracted to small town wants that old school feel of going in. But myself personally, what I experience is just what you said. I got an appointment with a specialist, a neurosurgeon, about my neck MRI. 2-hour drive to the city, to Portland. I'm like, I don't even think I really need to go to this guy. I was gonna cancel the appointment. But I thought, oh, he's offering me a telehealth appointment. He can review my MRI. He's going to talk to me clearly. If he thinks I need an exam, I can make the trip up there. But it's a first evaluation. I just pay my copay. Why the heck not? This is awesome. And it was great. And I know just from talking with other people, I think, a lot of things can be done this way, follow up post-op visits, etc. And I think that it's changed since COVID. I think our bias in small town, rural, urgent care might be a little different, because I think just knowing
Yeah, but I think that the next I think as the millennials age into requiring more care, they're going to demand not having to go in.
Yes.
I was going to ask you if it was a generational thing.
Yeah.
I could see.
Yeah.
There was this incredible model at McKesson for congestive heart failure that, at the time it evolved. So McKesson probably has the largest number of pharmacists in the country working for them, and very talented people. But it started out as just a service to the Blues. Basically calling up and getting weight and all these other kind of things. And McKesson looked into the details, trying to optimize it, because at that point they were getting just paid for the phone call. And they discovered that the variants of a disease, because at the time, and this is dated, so don't hold me to these numbers, but congestive heart failure can go from $35,000 to $250,000 a year in maintenance. If you sort of get to the right side where things are bad, it gets expensive really quick. And so you're looking for sort of some statistical process control and keeping people going. Well, these results were amazing. They had a really tight performance. And what they discovered in the nurses, they had 7 minutes scheduled for a phone call. And the nurses realized a lot of these people weren't mobile. So they got to know them. And what they the nurses decided that instead of if someone was out, it just went to anyone. They teamed up, and so no matter what, they were having a personal conversation. So these patients learned that if they were in compliance, they would have a 2 to 3 minute data dump to them, and then a 4 or 5 minute visit, or a 7 minute lecture. And so what strangely happened is they had great performance. So, Tim, to some of your point, it's motivation, right? It's behavioral aspects of the system, because as doctors, you don't, you aren't always told the truth. We do a lot of research at Carnegie Mellon, and there was a sort of a research. It was an opt-in research, so this is not something that big institutions could do, but basically they were asking patients if they could follow their social media. And what they found is what they said they did to the doctor and what they were really doing were two very different things, right?
Well, I know that even as a patient and a doctor myself, I'll say, "Oh yeah, I'm not overdoing it."
Or
I won't.
my father's generation, he's unfortunately passed, but I would go to the doctor with him near the end, and he wouldn't say stuff, and I'd say, "Dad, like, this is going on," and he would say, "Well, I don't want to bother them. They're busy." It's like, well, or I remember being at Johnson and Johnson. We were doing one of those sort of customer testing things with another division where it's, you're all behind the screen and there's sort of an interview going on. And it was for sort of a prostate sort of issue. And so there's a bunch of men in the room, but one man brought his wife. And so they're asking all these technical questions about, are you spilling? Are you, having these issues? And no one's saying anything. And so the woman finally said, none of you guys are having this issue. And the whole room opened up, right? And so it's really about understanding and having actionable, truthful information. And one of these things that these information technologies can do is, I can look in your watch and find out how many hours did you really sleep last week? What was your pulse really? You say it's okay when, the people say, well, my pulse is high because I have white coat disease, right? When I go to my doctor, and it's like, well, no, your Apple Watch has basically said you've been at 80 something for a while now. So I think, your blood ox has been down. So I think that these are things that can help physicians a lot.
So let's talk about that a little more in terms of, because for our listeners that aren't in healthcare, and we could sit here and try to dissect and bitch about healthcare and the ways to make it better in America from our own point of view, being in the system, and same with yours. But for patients, we were talking about what can they do to make better changes to their own health, but also provide that information, like we're talking with the AI, to their physicians. Is that going to be helpful? So let's talk about the providing the information, the tech that's available, from things like your Apple Watch to an oximeter to even following your iPhone and what you're doing. And then I'm excited to talk about how this could be helpful in preventative care and making things better, but also now the big freedom push with what happened with COVID, and people, it's like, my health, my choice, or none of your business. I don't want people following me. I can see that being
I think
a big obstacle.
yes. I mean,
so let's start talking about that. Why don't we, for instance, I won't wear an Apple Watch. I refuse because I don't want them tracking when I'm sleeping. When I'm like, I freak out when I see ads pop up on my phone. When I was talking to Tim about a movie that we should watch, and the next thing I know, it's on there because they can hear, and or they track what you're looking up. So there's times when I'm like, I don't want them to know my business. Other times in health, yeah, it could be helpful. So
and I think it's there we can talk about generational, because I joke with my kids that by the time they figured me out, I'll be dead. But think of all the dumb things we did as kids, right? And so it's all being tracked now, and there's a lot of pressure. And I think that's a real situation. But I also think you can set your Apple Watch where this is private information, and you can self-manage. So I think part of it is taking responsibility for your own health is step one. And I know we were talking about my daughter's out in your area, and so there's a lot of young people moving out there. And I just had this discussion with one of my daughters. Have you signed up for a primary care physician yet? And so get into the system, as and I don't need an annual visit. If you're looking, I don't know if you can see this on the camera, but on my tip of my nose, I actually used my wife's makeup today because I got went to the dermatologist and she burned something off. Right, no big deal. But I had a friend that had melanoma and a real serious journey, and he just simply had never gone to the dermatologist. Go once a year. So I think that's step one. And step two is you can get these data elements into your life and track yourself and decide to share them and not to share them. But you can share them when you actually physically go to your physician. So my Apple Watch and all my data does not track, but I bring in a piece of paper. My primary care physician jokes with me, am I getting what my PowerPoint presentation he's getting every year? But I track it. I track my weight, my blood pressure. I can tell if I go up or down 10 pounds, my blood pressure changes. I had a drink last night. My REM sleep was down. I mean, just these kind of cause and effects that I would not have thought of without these devices.
So I think just to hop in here, I mean, a lot of what you're saying is stuff we use the old fashioned way. We would have people check their blood pressure at the pharmacy, write it down. You're right. Any sort of cause and effect from changing their medication, weigh themselves every 3 days if they're on a diuretic, that kind of stuff. So this is just using new tech, new tools, but being in control of who gets access is really the key.
Yeah, I think it's your choice. And I do think it's, I think at some point we might incentivize people. I mean, we've heard people, if you go to the gym and document you go to the gym, your insurance company is going to charge you less. I think that's a reasonable and fair thing. You decide to be a smoker, then maybe you do get, charged a little bit more. So I think that, we have those sin taxes as it relates to purchasing the products. We might find that we're going to end up someday with these kinds of things. But the question is motivation and taking responsibility. There is, I noticed a generational aspect with doctors where they walk in and they like, doctor, fix me. Right. And I do think on certain diseases over the years that I've been, doing rounds with doctors where a diabetic, a cardiology patient, end stage renal patient will say, I always thought when the doctor told me I got to that line, I could come back. With certain diseases, you don't come back from that line. And so don't go to the line. But that's, people taking personal responsibility. And there's a really interesting, I have been involved in some public health research in economically deprived areas, and access to quality food and things like that. There's other implications here that there's a program that our school was involved in where the right food was given to people, but this population didn't know how to cook it, didn't have pots and pans, or had one pot, and so I think that it's a very complex issue.
That's always been, our personal belief, and what we've tried to encourage with our patients throughout family practice and then into urgent care, is that personal health. I mean, you're personally responsible for your health, but yet it does also trickle down into the whole society and then the healthcare system. Because if we're not taking care of our health, and you're right, then things that are reversible, diabetes and obesity, and consequences of lifestyle choices, then it does have a big impact, obviously, on the whole health of the country, and then the pocketbook and the healthcare system and dollars, as we're treating all these people with expensive medications and getting to endpoints where we're doing surgeries for lung cancer if we could have prevented smoking, or gastric bypasses on kids to adults when we could have changed. So focusing on that awareness, prevention, is always
and realizing maybe that the dollars that should be spent there is not in the procedure, but some behavioral psychology to figure out why they're eating in the first place.
Right.
Well, and I've
and then we go down the trail. Tim's going to say that's not the doctor's job, and that's what we put all the emphasis on, is putting it back into the healthcare system instead of.
Right, but that's exactly where I was going to go. You read my mind.
Highly educated, highly expensive health coaches.
No, but that's exactly what we've done. We've with the metrics, with MIPS and MACRA, which we may do an entire show just on
you
how
should explain
primary
to people what
care
MIPS
doctor
and MACRA are.
Yes, primary care doctors are incentivized by essentially getting payments back to them on a contractual basis, whether it's every quarter or at the end of the year, depending on the insurance company, based on things we do that are preventative. So, how many people do you have that has, adequate blood pressure control? What percentage of patients have you sent for colonoscopy? It goes on and on. That's why when you go to the doctor, if you haven't been seen in 6 months, they ask you how many beers do you drink? Do you feel safe at home? Screen for depression, all of these things. I have my own opinions on how that sort of corrupts the relationship, because now you have a financial interest coming in, that's really, in a way, getting between the doctor-patient relationship by telling me how I have to practice medicine. So that's sort of a philosophical issue I have. But most of these metrics, in fairness, are reasonable. Like these are things we should be doing from a preventive perspective. But it's life coach. Now I'm a life coach. So you've taken my training and my experience, and we did, I delivered babies for 12 years. I worked in an ICU. I did hospitalist work. I have a lot of tools in the toolkit on treating disease, but I'm a terrible life coach because I've never been trained to do that. But you're going to reward me more as a primary care doctor if essentially I'm doing life coaching stuff. Why don't we just, like you said, because it's the entire donut, it's the whole system, that 18%. Why don't we just hire more health coaches? I mean,
it's, and there's some diseases, as that we've sort of figured that out. End stage renal disease and diabetes is actual codes for training, but not in these other areas. And I had done a series of qualitative market interviews on neurologists, and really started to appreciate, they have their patients. When you think of Parkinson's and all this, they have their patients for 20 or 40 years. And so they're watching out for caregiver fatigue and all these other things. And the doctors, it's a very personal relationship. People say, hey, healthcare is becoming what these folks are really engaged and involved in their lives. But to really make sure communication has happened, they're hiring, nurses and physician assistants to help with that. But in many cases, they're not being paid to do that. They're losing their own income to provide that service. And so I think it goes back to all these quality measures. When healthcare reform started, just for your audience, we're measuring insurers, we're measuring hospitals, and the last group to get measured has recently been the physicians, which is a MACRA and a MIPS code. And so what it's all about is we're going to measure these things, and if you do goodness in them, we're going to reward you, and if you do badness in them, we're going to penalize you. And like any system, it starts out really crude and unfair. It really does, until we get sophisticated. And so I bring up those two diseases because for whatever reason, over the years, someone had figured out that there's more goodness in paying for this education and this
right,
I'll call it bringing people from illiteracy to literacy. And I think that's even in the school systems, my parents are educators. We've dropped the amount of time we spent on health in the education system when, I remember having diet and other things. It's not just about reproductive health. It was also, it's a health at the time, but those resources are going down too. So I think
I was just thinking of, exactly what you said, thinking back to growing up in as a kid. Now this might be a crude overgeneralization, but we had the home ec class that we had to take. So we're talking about the pots and cooking. We learned how to, it was like mandatory in junior high. You learn how to do cooking. Well, actually it wasn't, it was mandatory. You could do shop, you could do woodworking, right? There you go. But learning about nutrition, it was nutrition and how to cook. I mean, basic, but very important. And the food groups and getting an understanding what's protein, carbs, fat. But even the dentist, I remember, so we'd go to the dentist, right, for cavities, but the dentist didn't teach us how to floss and do it. We had it come into our school. I remember.
Yeah,
yes,
exactly.
the health nurse would come in every 6 months, and then they would check our teeth and then do the fluoride, and they would give us that stuff you had to swish, and your teeth would turn purple if you didn't brush right, and everybody would freak out. But it was preventative stuff done there. So I know, of course, we always talk about even the teachers don't have resources, but why can't we look at, instead of just waiting till we get to these horrific endpoints of obesity, et cetera, and trying to now fix it when it's too late, go back to the basics and look
Well,
at
and there's
putting
other
healthcare
lobbying.
dollars into that.
Yeah, there's other lobbying groups that are causing these issues too, right? If you think about, I can get a Coke in Mexico that has sugar in it. I can't get one in the US. Well, the size of a particle of sugar, my body knows when to stop, right? And so there's a food lobbying thing that's going on
Right.
here. There's chemicals that just aren't allowed in the food system in Europe
Right.
that are here. So there's so many cause and effect in public policy decisions, and I think that we just, if you look at how our government, so again, at Heinz College, they have one of the top public policy schools in the country, and our students are very much involved in government information. And if you're anyone who spends time on these databases, which I do, in the past decade to 15 years, its sophistication and access and ability to analyze has gone up. I would say fivefold. So hopefully, in the next decade, we start with this artificial intelligence. We start educating ourselves on facts, and I think we learned yesterday the cost of non-facts is about $787 million. But
Mhm.
I think we got to get back to facts, and some of these are public policy decisions that, if we're made, would impact healthcare in a very favorable way, that these choices just wouldn't be available. These chemicals wouldn't be available, right?
Right, but when you look at other chemicals, and you've been in the industry, you work for Johnson and Johnson and so forth. I mean, chronic disease is the I'm trying not to be crude. It is the fever dream of big pharma. I mean, it really is, because we used to get detailed on antibiotics, and there'd be a new antibiotic every quarter or something like that. Well, that's all gone away. Like, everything now is like it's like, start a Prozac, never stop it. Get on your expensive Lantus, never stop it. I mean, the business model has gone from, okay, you're going to take a little bit of anxiety medicine for 2 or 3 days, or you're going to take heartburn medicine when you eat pizza, to you're going to take Privosec every single day. And you're like the chronic disease model, where you're chronically sick, means you're also chronically buying
Product.
pharma products. And I think that there's a real issue there. I mean, it's the perfect market. Like, you even look at what happened in vaccines. Kids are getting what? The CDC last week added 7 more vaccines to the vaccine schedule. So we're over 80 doses by the time you're 15 years old. I mean, it's hard for me to go, this is just all goodwill.
Sure. I mean, well, there's numbers out there on what it takes to get a drug approved, right? And they're hard to really appreciate or understand, right? People say it's 1.6 billion to $2 billion. Well, that's because only 2% of the starts come out the other end, and when they take
Right.
that number, they're talking about all these failures. But we have to start applying, and people are, artificial intelligence and new tools to bring down that cost. And I was fortunate enough to be involved with the inventor of high content screening, and he would say fail early, fail often would be his mantra, right? That would bring down the cost. So that was his personal mission. But I do think, again, it comes down to, um, people are going to move towards their profit motives for sure. I was out to dinner with a business school friend of mine. I hadn't seen him in years, and he's doing the Prilosec. And I said, Sean, Bragg's vinegar, 2 tablespoons a night. In 2 weeks, you will be off this stuff. He didn't believe me, so I mailed it to his house. And he texted me the other day, and he said, I've been on this stuff for forever. So I think, now this is a CEO of a big company, so this is not a unintelligent man. Um, just again, that's an illiteracy right there, right? So I think
So,
it's a
what?
challenge to people are going to move towards their financial incentives.
Right. Obviously, it's the business. What are your thoughts then for, like, I'm thinking as far as the patients go? We're talking the cost of healthcare and what do we do to change that? And you're right, it's business everywhere, and pharma has an interest, and the food companies have maybe an interest to make you buy crap and sugar because that's what they're selling. So with all the tech out there that we've been talking about, as well as the ability to educate yourself on the internet, like our kid says, what you went to a library? How did you do a research project or write a paper ever in your life without Google? They just Google everything, and you could teach yourself to do a
I
brain
think the
surgery with
exact quote
Google.
was, "How did you get through medical school without YouTube?"
Yeah. So people can self-educate on so many things, um, to maybe then get better care of themselves health wise. And I'm seeing that all over social media. People are learning and asking questions, but you have to have the incentive to do so. There's a lot of people that aren't
And you have to have the
incentivized,
access. I
and
mean,
the access.
I
There you
think
go.
the educational system learned during COVID that we have these broadband deserts. I mean, even in Pennsylvania, you have Philadelphia on one end, Pittsburgh on the other, and in the middle there were a lot of towns that kids were going to 40 minutes to a library to get access. I mean, that's you ask yourself, is that a utility? Is that like, when we put electricity and gas and fuel at the founding of the United States, we told utilities they had a certain obligation. Again, I don't know. It's a complex topic, so I'm not going to solve it.
No, interesting. Good point.
But I think
Because I was going to say then maybe the onus should be on patients and people
it
and the
is.
general
I think
public more, because I've always liked the idea of a sin tax, so to speak, with health, because we
Well,
do it with our driver's
yeah.
insurance.
Well,
I've
other than liquor is taxed too much, in my opinion, but that's my own issues.
Well,
Uh,
we do it with your home insurance. We do it with driving your
right.
automobile. If you crashing your car all the time, they're
sure.
going to take your license away or raise those rates. So
So
maybe
I
there
think,
should be something like that.
part of the discussion is a little bit of this right and privilege piece, because not everyone can do the things that we're talking about. Not everyone has the access, has the education, and all this. So what do you do with that?
Right.
And so we can talk about these responsibilities, but if no one has been brought up where they have these responsibilities, it's a whole bit of education and investment that needs to happen. And so the question is, do you make that investment or not? And it comes back to the story of the woman who drew this boy home from engineering school. The answer is probably yes. I mean, there was a big social experiment in France about 25 years ago, as it relates, maybe it was 30 now, as it relates to welfare. And what they decided to do was pay the parents to make sure the kids had medical and education, and they stopped a generation of people being on welfare by changing it from paying the parents, but paying the parents to take care of the kids in a certain realm that made a very high probability. Now it was probably a 30 or 40-year journey for them before they saw a result. But these are the kinds of things we need to be thinking of.
Right. I mean, if you're gonna spend, I get it. I mean, and I like this because I love this discussion because you know we can we can rant and rave to ourselves, and trust me, I have done a lot of ranting and raving, and we have our own political biases, and mine are usually fairly obvious. And but it's a balance point. Like if you go to somebody that's fairly conservative like me and you say, look, we're going to reduce welfare in 25 years or 30 years by changing the incentive structure, but we're going to have an input cost increase of 10% over the next 10 years to do that. Would I take the bet? I mean, if you could convince me that outcome would actually happen, of course you'd be crazy not to, because seeing what we're doing now, you're already spending money on these social services, but you're making people dependent on them, and then you get into which we've worked in poor communities for virtually our entire career. It's generational dependence. Well, that's not what you want, because economically that's a disaster. It's not just expensive because tax money's going to it. It's expensive because you're taking productive workers out of the economy, which is really what your economy is. It's the measure of how much production you can get out of your society, and how happy those people are producing those things. I mean, that's kind of the measure of economic and social wellness, right? I mean,
I
people are
agree.
happy to go to work,
And paying
and
for the
they're
value. I mean, in the 70s and 80s, we were being hammered by Japan for our manufacturing techniques, and we focused on lean manufacturing techniques. And there's this thing about your goal is to get rid of the non-value added. Well, if you put that in the healthcare system, the value add is literally the doctor and the nurse, and everyone else is non-value added. Theoretically, everybody else is non-value added. And I when I teach, I hold up an American Express card and a Visa card, and I say, why will some places not take this? Because it's 1% more. And those operate at under 3.5%, probably more like 2% these days. But legally, our insurance companies can get up to 20% and keep it of the money that flows to the system. Now, today they're roughly at 15%, and it's getting smaller for sure. But what is the value that they are providing when I have physicians and nurses leaving the system because they're exhausted, they can't pay the rent, doctors can't cover the cost of medical school. So there's some just strangeness in our system that needs to be sorted. And again, it's where's the value, right? So we talked about the illiteracy issue and who's going to solve it. Well, a physician having an extra nurse or someone that can have an intimate relationship with the patient is more likely going to change that patient than receiving digital media from an insurance company. Personal opinion.
Yeah,
So
let's talk about that a little
No,
bit.
100%. And this is my analogy. I've switched over from air tools to electric impact wrenches. I like to build cars, and they're great, but they're really great at doing what impact wrenches do, which is like removing stuck bolts and whatnot. And they're expensive, and you have to charge them up, and you have to maintain them, which is like the doctor. Okay, I mean, we are essentially specialists. I didn't go to business school. I can't work for a business. Like, I can't run a company. That's not my skill set. And you would never want to work for that company, I can assure you, because it would be broke. But most of what healthcare needs is hammers. So, this is how you should eat. This is how you should exercise. This is how you check your blood oxygen. This is how you take your blood pressure. Those are simple, inexpensive things to educate people, but don't use the impact wrench. Don't use the highly trained person to do that. And you'll probably get better education from people that are, motivated to be a teacher or a coach, or however you look at it. And most physicians aren't that. I mean, we look at things in a certain way. We're very risk averse. We don't want to waste I don't want to waste. You think of these guys, even a generation removed from us. And it's like, why would I waste my time talking to them about whatever when I can, see 10 more patients and cure disease? And I'm an advocate that the doctor side of healthcare shouldn't be preventive based. It should be disease based, because you want your sharpest tool to be very specific and very skilled at treating the bad stuff. But we need to spread out more resources in getting more foot soldiers out there doing the literacy part, which is exactly it, because it just never ceases to amaze me how disengaged some people are with their health when it affects it's their life.
mm-hmm. Yeah. I mean, my wife and I have a concierge doctor that we see that we pay out of pocket. And the first time, I mean, I had a very brutal divorce and figured that I probably had some health issues, or if I didn't, I was probably in a bad state and I needed to check this out. So this is going back 15, 18 years ago now. And so I went in, he drew 28 vials of blood. And there's a cardiac marker, CRP, right? And it's an inflammation marker, and it's an indication whether you're leaning towards, some heart issues. And so 10 is high. I was at 13. I've been at 0.1 now for almost 17 years, with just a few little adjustments that he educated me on. My glucose at the time, absolutely in the green from any Quest test, but he said, at your age, given this trajectory, this is where you could be when you're 70 years old. Made some changes. My wife would want me to share this information because she's an advocate for it. She has Hashimoto's disease, which for your audience is, a thyroid that's dying at a certain rate. So if we all had Hashimoto's disease, in a strange way, having no thyroid is easier to manage because I can figure out your weight and metabolism and get you pretty settled pretty quickly. Whereas with Hashimoto's, it's constantly changing. And so she had these issues where she was gaining weight, eating like 500 calories a day, and had symptoms of neuropathy. She thought maybe I have ALS or Parkinson's coming. She had a lot of fear for a while and kept it to herself. Um, and so we finally got her to an endocrinologist, but they would see her, test her. So it was like the 6 month window, and they couldn't get her meds right. So I just happened to be talking to my concierge guy, and I just shared her situation. He looks at me, he says, "My wife has Hashimoto's. I can fix her up in a heartbeat." Long story short, um, there's a T3 and a T4 compound. Endocrinologists only do one of them. I don't remember which one off the top of my head.
T4.
A T4, and to get her settled, she needed these micro adjustments over the course of a year, which she couldn't possibly see enough endocrinologists to be able to get that, because they're like, come in, test, come in, test it, come back in 4 months. And she has been fine for going on 12 years now. I mean, lost the weight, energy, exercise, she's got an entirely different life. And so we're privileged to be able to afford that. The question is, she could have maybe been on disability or something if we went down the traditional path. So I don't know the answer to the question, because that's a very privileged situation. But think of how many people we could make productive if we could, have our health system figure out that the rules should be a little more curious.
I think what I'm hearing from what Tim was asking and what you're saying is that it's the physician you had that got her well knew and understood that and had an interest in that. The neurologist or who she was seeing before have a cookbook way or a certain way that they're trained in Western medicine. I mean, we fall in trap to that, and certain things we've learned. I would say we stink at hormone management. We just weren't trained in it. We stink at maybe understanding obesity and metabolic syndrome because of how we were trained. And so finding the person, and it might be your primary care doctor, your concierge, your specialist, finding that person that has that knowledge. But when you mandate people to do it by insurance companies or whatever the system is, when that's not really what your training's in, that's not what your heart's in, and where it could be done by somebody maybe with less expensive education and cost to the system, such as like a nurse practitioner or a nurse to teach those classes in a group. Why wouldn't you do that? Because you're going to get better outcomes. And as Tim and I always say, and we talked about this earlier, if you're having doctors or even specialists go away from their craft and what they love, what they're good at, to do other things such as paperwork and tasks and things that they don't enjoy, they're not good at or trained at, then we get this burnout. We lose doctors from the system. It ends up
Magic
costing
word.
more.
Yeah,
Yeah.
I think the word craft is a very special word, because I think there's two root causes to the conversation that I just had. One is, was the doctor educated in this, yes or no? And two, did the system allow this particular physician, yes or no, to be able to do T3 and T4, which I suspect not.
Right.
And I think when I talk to some of my top doctor friends that have time to think and have time to ponder. And I just did a series of qualitative physician interviews for a company, and went through these Parkinson's disease patients. And I just literally was crying listening to this doctor's story. So the story is a 42-year-old woman who's pretty unusually advanced for her age, and she had a specific branded drug that made her really stop the tremors, and she could work. And so she had a young family, and he's sitting there, listen, this isn't a 60-year-old person or 65 that can retire. This is a woman who's got 20 years of participating in a very active family life. And so they wouldn't give her the drug through the Pharmacy Benefit Management Organization. He worked with the pharmaceutical group, and he got her on a 2-year program, and that program had just ended. And literally she went back to where she was a week after it went back to the non-branded medicine. And this angel doctor has been spending 15 hours a week trying to get her on the right meds. What's the right thing for society? What's the right thing for that family, right? How much more is it really to have this drug? So I think there's a lot of putting our head in the sand like a ostrich and saying we're not paying attention to these subtle issues. And going back to Tim's point about the measurement system, these are the important measurements to be understanding cause and effect. And unfortunately, we're just too young at this measurement piece to get to that point of really getting enough data to impact policy. Because let's face it, what policy people do is they look at the data and they make the best decisions they can. It's not that they're evil or they're trying to squeeze down the system. They're just trying to do the best they can with the evidence that they have. And when I go back to that end stage renal disease and diabetes, the impact and the data was so compelling on this education that they finally decided to pay for it. So, in these other diseases and these other areas, we don't have the data yet.
So I want to, as we get this far along in our conversation, I want to throw out something and see what your thoughts, thinking forward with what's coming down the pike in healthcare with technology, but also we talked, we were talking earlier before we started recording even about what's happening with physicians and burnout and a lot of MDs getting to be our age, 50s, 60s, just pulling the plug. Even, gosh, I'm on so many forums where these people are barely making it through residency and burning out, which is sad. And I think they might have had the wrong motives or wrong education on what to expect out of medicine. But aside from that, losing physicians at a rapid rate and being replaced by mid-level practitioners such as PAs, NPs, what do you see? I mean, what are your thoughts on what you see coming down for the next 10, 20 years for us as we get older and we're looking back at the next, at the people taking care of us? What do you see? Have any wisdom of what's coming, what to expect?
So I can tell you the journey that I went on. So on my healthcare data website, I have a new physician report I put up there. And so as I was gathering the data and getting very upset over it, because at the same time, it takes 15 years to make a physician, right? So I would argue that for some of the people, like they're not sure what they got into because that wasn't what the environment was when they went into it. Mm-hmm. And a lot of physicians tend to come from families of physicians and the world changed, right? So that's one piece of it. But there's, two organizations that control how many physicians are made. And we clearly have a huge shortage coming up. And so I was really angry about that. And then I did the data and realized the baby boomers are the pig and the python. They're coming through and they're going to be in there for 40 years. And if I had produced all the physicians that I needed to get there, I would have way too many physicians 20, 25 years from now. So I thought, oh, well, this may be some insight here. So we are going to have an overabundance of physician assistants and nurse practitioners. And I think that we have to find a way to get them into the system and have them, the physician be a coach of these folks. But again, this reimbursement has to happen so that it's affordable to do it. So I think Destiny is going to do that. I don't know when and how. I think Destiny is going to do that.
Yeah, and that makes absolutely perfect sense. Like, why would you take somebody like with my level of experience and training out of the system because I'm the grumpy old man when I could be coaching an entire team of people with less training than me and less experience, and some of those might even be junior physicians, and I could be doing it from my pool in Florida. Like it doesn't.
And I think too, it comes down to, Kaiser is a great system.
Yes.
But there's a term called normal distribution, right? So it's sort of like a little arch, and at the end of the tails. And so I wouldn't want to go to Kaiser for certain things at the tail. I'd want to go to a specialist that's somewhere else. I think that same story can apply to the physician assistant and the nurse practitioner to the doctor. The doctor has all this experience. They've seen the tail of the variants, and I want them focused on the tail of the variants and getting more volume on the tail of the variants, because that's when a specialist really sort of spots something really quickly. And if you've ever had family members that have sought, certain issues and find a specialist, and all of a sudden this person solves it in 5 seconds, and you're just sitting there saying, we spent 5 years on this.
Right.
That's what that specialist does. So protect them. Embrace them, they're Oz behind the curtain. Let them be behind the curtain coaching. And truth be told, with daughters that are nurses, when they have that kind of doctor that's sort of coaching them and helping them, that's the best job for them. They're really enjoying it.
No, that's perfect. Well, we were actually quite positive today.
I love it.
I
I
love it.
was so scared for this episode because I'm like, Tim and I are gonna just start our pitching. It's gonna dissolve, and it could.
No,
Yeah.
I read this Christian book called Unoffendable, and it's actually changed my life because I realized I don't have to be pissed off about absolutely everything in the world. And it's like, wow, this is way better.
Yeah, I picked it up. It's on my nightstand, so
Yeah, so
it's next for
and,
me.
and this was awesome. I mean, I love the ability. We so thankful that you're on the show to talk to somebody kind of in the industry, because
Thank you.
it's a perspective that a lot of us, especially as definitely as patients, but as physicians, we kind of forget about it. It's the guy in the blue blazer that fires doctors, or what, however you want to look at the MBAs in healthcare system. And yeah, I mean, it's important.
And we see things for us, because we've been in this location for almost 30 years in with our own blinders, like we were talking about, just living in this part of society in our little niche in the world. And, the country is a country as a whole. It's easy to not see how things are happening. You're right. Where you are on the East Coast, in a city, people, different socioeconomic groups. I mean, healthcare itself is, from the primary to the tertiary care centers. So yes, thank you for that.
At the end of the day, it's a personal business, right? So I've done a lot of startups where you do clinical trials, everyone in the trial, it's a personal business, and you can't take that away. And when we talked about bringing, the big companies, Amazon knows exactly what I'm probably going to order tomorrow. Now it's done through technology, but damn, it's personal.
Yeah, no, I had a really great conversation with yesterday, or the day before, with a physician from London, and she works in pharma, specifically in AI. And she was like, she sees Amazon getting into discount pharmacy almost like in the next year or so.
Yeah.
She said all they'd have to do
I
is,
already knew that. They were pushing that to me like a year ago, that they were going to do that.
but they'll take the production side
Yes.
too, because all they have to do is acquire one or two generic companies, and they can completely revolutionize what happens with prescription drugs. Which I would welcome that when you see what they've done for everything else.
So I think they'll do that in certain areas. At the end of the day, the ability to discover a drug and bring it through is highly specialized. I think what they'll force is like the Japanese force lean manufacturing to the United States. I think they'll force lean drug discovery into the US, and I think, or probably the globe, because we are the leaders in it. And I think it will be a painful transition, just like it was in those years in the 70s and 80s. But I think that will be the outcome.
Interesting.
Wow. Well, time will tell, and hopefully all three of us are still around when things, things will get better and things will get worse. That's just the way life is. And, so thank you again, Jim. This was wonderful. I know our listeners are gonna just love this. And tell us where. Yes, I was getting there. Where our listeners can find you. You have recently started a podcast, and your websites, etc.
Yeah.
So the podcast is called Chalk Talk Gym, and there's an amusing story to that. But if you go chalktalkgym.com, and again, it's very aligned with the show. It's a business model. So I'm only several episodes into it, but physicians, nurses, various healthcare hospices, trying to get everyone involved, because again, if we're trying to build one system, we all need to sort of understand. And so that's the nature of it. And my academic website is healthcaredata.center instead of .com, and that's also oriented towards that education. But my personal website is jfjordan.com, and you can see my speaking engagements, and I've got a couple books that I've written on startups and intellectual property, different things like that, and you can find me there.
Perfect. We will link those. Now, you have to share how you got the name Chalk Talk. I was thinking like chalkboard basics. No,
so I'm a very detailed person, and that's been my success, but I can't always explain it. And so I've been fortunate enough to have some talent around me in my life that sort of did I'm thinking of the old Saturday Night Live, news for the deaf. He said, that kind of thing.
Garrett Morris.
So I have a friend of mine that has worked with me several times, and I'm fortunate to have her respect even when she doesn't understand me. And she throws a magic marker at me and says, do it in the whiteboard. And for whatever reason, when I'm stand up and talking, or I'm doing something on the whiteboard, I'm very clear. And so that's how I came up with the name Chalk Talk Gym, because having done sports and stuff, that's what we did when we were kids.
I love it. That's
Yeah.
awesome. That's perfect. Well, thanks again for being here with us. And as I said, I'll put the links up for our audience members to find you. And also, I'm excited to check out your podcast and listen in to see how that's going. So thanks again.
All right. Thank you so much.
Well, what did you think? Did we solve all of the problems in the healthcare industry?
No, we didn't. And actually, like he said, that took a little different, bit of a different turn. Well, maybe than more that he thought than I did. But I really liked how we honed it in, and we hope that you, the listeners, that are not in healthcare working per se, got some really good insights and perspective, and we hit the ball back in your court, maybe in ways that you can impact some change, things to think about rather than listening to doctors and nurses and people in healthcare complain about the system. What do you think?
Well, yeah, I mean, I guess the hard part, and we kind of alluded to it, is the financial incentives are really kind of crazy
And so complex, right?
and until
You
that,
can't really pull one Jenga piece.
no, you can't. And so how do you get financial incentives aligned to make the system better? And the answer is it's going to have to come from outside the system. Like there's no other alternative to this. So what is outside the system? Outside the system means you're going to have cash-based things like direct primary care, direct specialty care, where people just pay and say, I'm done. I'm done with the benefits that I get from my job because it's way more expensive for me to pay my copays and my premiums than it is to just pay outright. So there's going to be that. There's going to be technical stuff, which is Jim's kind of area of expertise, that with using artificial intelligence, improved diagnostics, et cetera, et cetera,
Yeah, I
et
think you're
cetera,
right. There's all
that's
these
going to
different pieces.
shrink costs and I think advance health. And then I don't know, there might be stuff like where we just stop paying for things. I mean, times could be bad enough, right? I mean, Genghis Khan did not become the greatest conqueror in the history of the world because he had a great healthcare system. He did it because he had the biggest army. So
yeah, from this talk, I
who
basically
knows?
got that, we were always looking at it from the point of view of this big entangled ball of wool or ball of, I'm going to say extension cords, since we always seem to have a plethora of those here, or your jewelry, women, your necklaces that get knotted in a big knot and you're trying to untangle and you pull one piece, but that doesn't do it. And you're trying to then pull a whole bunch of pieces at once, trying to untangle the mess. I think what we're saying is that someone's going to come along from the outside with something new and innovative, and as everyone's trying things out, and it will be like just taking the scissors and snipping it all apart, and surprise, something else comes along that really makes a difference. Isn't that what you're saying?
Yeah, no, and I think it could be incredibly fast and incredibly surprising.
Yeah.
Like when you think of what's happening in nanotechnology and AI, when those things merge into one entity, where you could literally inhale nanobots and they just go in and kill your cancer. You inhale nanobots and they adjust your genetics so that you don't get cancer in the first place. Like that.
Well, we're going to have Terminator taking care of us, and Terminator killing all those bad.
Well, you will become the Terminator,
and
because
that too.
And if Michael Crichton has been almost prophetic in a lot of the stuff he's written about in his novels, even though he's been since deceased for 20 years or so. And you read that book, Swarm, about nanotechnology merging with humans, and then you get into the guys that are getting into all this transhumanism, and all of these things are going to intersect at some point. And
I know, I love it. I just look back and think to when our kids always asked us how to get through high school or med school without the internet, and we're like, internet? Well, we didn't even have a sniff, and now we have these little phones with the world at our fingertips. So I think healthcare is going to be like that too.
No, and I think and it's going to be in ways that are literally like Swarm, where you inhale nanobots that, I mean, everyone is going to have six-pack abs and be perfectly.
So I can just quit now?
No,
while I'm ahead.
We don't have that yet, but I mean, but
Anyway.
if you look at where technologies are going and how people predicted things that were correct, in the 70s. I mean, I remember going to a futurist that did some speaking at churches. It's kind of a long story. And he was holding something that looked kind of like an iPad size. And he says, "You see this?" And it was, a wallet or a card. He said, "Kids will go to school, and that will have 100% of all of the information. Every textbook, everything will be on something that big that you can carry around." And now it's on something that's half that size.
Right.
And so if you would have said in 1972 that you were going to carry like a phone, but you would have access to the sum totality of all of the knowledge in the world on a device that was smaller than a cassette, than a cassette tape that was just barely emerging as a technology in the early 70s, because we still had 8 tracks until like 1981 or whatever it was. When you think of that, and then you think of where technology is now at the very edge of we want human machine interfaces, et cetera, it doesn't sound completely insane to think that you'll inhale nanobots and it'll make you whatever you want to be. So healthcare it won't exist. It will just be completely overwhelmed by technology. Going to the gym will be a joke, because the gym will be snorting nanobots.
As long as I don't have to keep dyeing my hair every 6 weeks, saving
You
all that
won't.
money.
Do you want it curly? Do you want an afro? Do you want a beard? Do you want to transition to the other sex by inhaling nanobots? Like, seriously, like,
wow.
this stuff is.
Yeah.
People think about this, and you're a weirdo. This is if technology continues in the same direction it's going. This, maybe not in our lifetimes, but that is the direction it's going.
And on that note, you actually had a really interesting interview where you were a guest on someone else's podcast talking about artificial intelligence and healthcare direction. Isn't that right?
Yeah, and she said something that was super fascinating. She is a doctor, and she said that they're getting very, very close to using artificial intelligence to the point where you will not have clinical trials.
Oh, right. That's what you said.
Where you will
Well,
use
hallelujah for that. Right?
where you will use digital copies of people and add the agent that you're the digital copy of the agent that you're using, and then you just see what happens.
So no more monkey, rat, and guinea pig studies.
And it's exactly the way we've been designing parachutes and boats and all of these kind of things for the last 20 years. They're all done in CAD/CAM engineering. You can see exactly how the parachute opens digitally, and then they build it and it works exactly the same way.
Right.
And that's coming to
fun stuff.
Medications.
Fun stuff.
Yeah.
Yeah. Well, stay tuned for all that. And if you're listening, Tim's probably actually off in the wilds of the rest of the world, in the sun, on the water, getting a tan, as this is pre-recorded. So pray for his safety and return. And we'll keep you up to date with our Doc Tales with Cocktails episodes live as we bring them to you on Wednesdays on Facebook for now. I think we're publishing them onto YouTube later. I don't know. Correct me if I'm wrong. So check us out on Rumble if you want to watch this video. Doc Tales at 5 Pacific.
6.
Oh, I'm sorry. 6 p.m. Pacific time. And we will see you next week.